So we're done with the general management. Let's go now into specifics. Let me just quote a few things in this last page. Now for ACS, which is for cardiogenic shock, we'll go to a separate chapter. As for anaphylactic and neurogenic, because they're not discussed in chapter 11. Sepsis is here in this chapter on a different page. As with fluid administration, because the fluid administration in shock is rapid, we're talking 1 to 2 liters per hour. So what could go wrong? Fluid overload. Or it could be site-related complications as well. We're talking infiltration. Or if you have, because we should not give vasopressors through a peripheral line, but it happens. All right. So we're concerned because it takes a while for a doctor to be available and insert a central line. So meanwhile, we may start a vasopressor like norepinephrine peripherally. So watch for extravasation, okay? Because they're quite serious, nasty wounds. Okay, because they can cause necrosis, tissue necrosis if they infiltrate. And because all of these happen so fast, okay, everybody's in a hurry starting the IV, starting the fluids. So we may miss a few things and then we have infiltration. Okay. So here, this part talks about CVP, central venous access devices, okay, for rapid fluid administration, plus the, no, sorry, this one's talking about central venous pressure, meaning pulmonary artery catheter. They're becoming less and less popular now, especially among younger practitioners, meaning the younger residents don't like pulmonary artery catheters anymore, but they are still in use, okay, generally speaking. But more and more younger doctors are not really fond of pulmonary artery catheters. Because there are other ways you can measure CVP, non-invasive ways. Like here, for instance, esophageal Doppler, arterial pulse, cardiac output devices. So these are non-invasive options. Yeah, it's not a perfect science. I mean, to me, the hemodynamic monitoring central venous pressure is best measured with an invasive catheter. I mean, there's no, you can't beat that. Okay? You have an actual catheter in the heart measuring the pressure. I mean, what else could be better than that? But they do have non-invasive measures, which again, the only thing I can say about those, they're not really a perfect science. As with any central line, we have CLABSI. Did we do central lines last semester? We did, right? Yeah. Week 2, yeah. Okay. All right. For vasoactive medications, again, these are epinephrine, or more popular are norepinephrine. So your major concern there is the extravasation, which is basically infiltration. But when a vesicant medication like this infiltrates, we call it extravasation because they do cause tissue necrosis. Literally destroys the vein and the tissues around it.
This is different than when
like looks like you burn the area, but plus it looks black. No, it's an ugly wound.
that's different from the dextrose burning through the peripheral.
No, dextrose does not cause extravasation. They infiltrate, but they don't
No,
cause any
like when-
tissue damage.
If there's to be more dextrose than like 10 given, you don't do it in the IV. Is that different?
Yes, remember we did TPN last semester? Yeah, so any solutions greater than 10%, it should be through a central line.
Oh, that's not
Yeah, they're
necessarily
just too
the same
thick.
science.
Yeah. too thick to run through a tiny
Oh,
vessel. So whenever you see signs of extravasation, what's your number one action?
stop.
Okay, however, how do you reconcile it with this one? This
Oh, it shouldn't be stopped.
Houston alert.
So you take it off.
Mhm. But of course, if you have extravasation, you have no choice. You have to stop it. But what's your number one duty? Start a new one and then continue. Okay, so you should never stop norepinephrine, because what happens is it will cause a reflex drop. Yeah, a reflex drop in your blood pressure. It should be tapered. The lowest you can give is of course 1 micrograms per minute, but you go slowly. Okay, so for 4, you can taper. You can titrate by 2. You can go. Let's say you were at 8 or 16, and also taper titrate by 2. So 16, 14, 12, 10, and so on. So let's look at table 11-2. And this is for your CLABSI. This is your bundle, CLABSI bundle. You know what is CLABSI, right? These are your commonly used medications. All right, so these are your vasopressor medications.
What was it that you said about the neuroepinephrine? You said vasopressors
More commonly.
more common than
Mhm.
that's just it's more common.
But when it's like a heart attack, they are always using Cephalin. Is that
No, they use dopamine usually.
in the heart attack?
Or nitroglycerin. Nitroglycerin, and then
It's a vasodilator.
right, but it's more cardioselective. Okay, let's go to hypovolemic shock. And then, like I said, we'll do cardiogenic shock, separate chapter, along with anaphylactic and neurogenic, also separate chapters. They're mentioned also in chapter 11, but very short. Hypovolemic shock, this is the simplest. So the patient here loses 750 to 1500 ml of blood or fluids. So here are the risk factors. These patients lose fluids and or blood in one or more ways. We've talked about diabetes insipidus last semester. Burns will do probably in week 3 or week 4. This is the simplest one to treat. So the patient lost fluids and or blood. So what do you replace them with? Fluids and or blood. Now, medication wise, we really rarely give any, but depending on the underlying cause. So let's say, which medications can you give here for, let's say the patient has diabetes insipidus. So what medications?
No, desmopressin.
Desmopressin. Okay. You see where I'm going? Okay, so medication wise depends on the what led to the shock. So if it's, let's say, DKA, then you treat the DKA. Right?
Without the, no, it's without.
It's
the-
ADH, synthetic
without the
antidiuretic.
vasopressin.
So other than fluids and or blood products, the medications used will be specific to the cause, what led to the hypovolemic shock. So here under the next paragraph, treat the underlying cause. But for hypovolemic shock itself, it's only fluids and or blood products. And then again, treat the underlying cause. So since this topic covers blood transfusion, will you expect blood transfusion questions on the exam?
Absolutely.
Very good, children. That will include blood typing and cross matching. Okay. meaning, compatibility of the blood, and then procedure also, and also, remember I tested you also on which blood product is given to what
Right.
problem, okay, meaning indications for each blood product. So it's that quick. That's it for hypovolemic shock. Because again, we're not discussing the individual costs in chapter 11. Mhm. Okay, for cardiogenic shock, this is only for this one. Okay, since the number one cause of cardiogenic shock is myocardial infarction, so we'll discuss that next week on a separate chapter. So here's a short discussion on cardiogenic shock. There are really no specific symptoms that is unique, meaning exclusively on cardiogenic shock. If you look at the manifestations here, they're really the same as a heart attack, okay, or decreased cardiac output. That's it. The only thing that really makes it cardiogenic shock is the MAP is now below 65. Then they're in cardiogenic shock. Okay. But all the other symptoms really are no different from heart failure. The patient's in heart failure, left side to be specific. So manifestations are those same as those for left side heart failure, but the MAP now is below 65. And most of the time when they're in cardiogenic shock, the heart rate also falls. They go bradycardic, meaning the heart is decompensating. I mean, it can't respond to the epinephrine anymore. Okay, so that's usually what happens when they're in cardiogenic shock. So here, there's pain. So all, again, manifestations of usually a heart attack. That's why our number one exemplar is a heart attack. And diagnosis also, a heart attack. So treatment for cardiogenic shock, of course. Do we give fluids? Do we give fluids?
To keep the thing open.
We give fluids? Okay, very, very small, okay? If maybe 30 ml per hour, or the most you'll see is probably a 100, 250 bolus. That's it, just to challenge, just to increase blood pressure, but nothing more than that. So will this patient benefit from beta blockers?
Yes.
No, not during a heart attack,
No,
okay? Not
no.
during a yeah, so later when they're stable, okay, so not during a cardiogenic shock.
Also treating the cardiogenic shock.
Well, you treat them at the same time, really, because treating the underlying cause is essential to stop the cardiogenic shock.
Why don't we give those?
Again, if you give a beta blocker, what will happen to heart function though? Yeah, beta blockers are for stable heart failure patients. This one, a heart attack? No, no beta blockers. So oxygen first. And what did we do again? For no, we haven't done ACS. Okay, that's okay. So we'll discuss more of this next week. Because you can't really separate cardiogenic shock management from an MI. So let's do this. So we'll do this next week, okay, when we do acute coronary syndrome. That's simpler. So we'll talk about the dopamine. Okay, so these are the vasoactive medications. Not vasopressors, vasoactive medications.
What about the
Again, we'll do that as an option next week for heart attack.
That's the term ACS, that's abdominal.
No, that was different. Abdominal compartment syndrome. This one is the one next week is acute coronary syndrome. Okay, here's distributive shock now. So we have 3. Let's do whichever comes here first. Okay, since sepsis comes up first, let's do sepsis. Okay. This is the most common among the three. There is a long list of risk factors. Let's start with that first, chart 11-5. So what do these all have in common? Patient has an infection. So patient is either immunocompromised. So who are immunocompromised? Cancer patients, okay? HIV patients, who are bone marrow patients, organ transplant recipients, okay? People who are on steroids, okay? Yes, elderly or very young. Okay, so a high risk for sepsis. So less than 1 over 65. Malnourished, so this will include alcoholics, okay? Chronic illnesses, diabetes, COPD, high risk, or those getting any invasive procedure. So not just limited to dental, but also for surgeries. Okay. The longer the surgery, then the higher the risk for infection. Since they included the other distributive shocks, so here are your other risk factors. So spinal cord injury. Now, when you think of neurogenic shock, although yes, this occurs exclusively with spinal cord injury, but as far as spinal cord injury goes, you can sustain that after a spinal anesthesia. Okay, meaning let's say the provider made a mistake. Okay, so they can do that. Or let's say it can also be from the natural consequence. So let's say the rule is you're not supposed to receive low molecular weight heparin after an epidural, but sometimes they miss it. Some nurses miss it and they administer because it's different from heparin. Heparin is short acting. Low molecular weight heparin has a long half-life. So it can cause bleeding into the spinal column. And then now you have a hematoma there. Then you have a spinal cord injury. Okay, so that's how spinal anesthesia leads to spinal cord injury. But yes, that doesn't change the fact that only spinal cord injury patients can suffer neurogenic shock. But you can sustain spinal cord injury in a number of ways. So it's not always trauma. It can also be from diagnostic procedures like a lumbar tap gone wrong, okay, or a spinal anesthesia gone wrong. Yes, they can treat it. Anaphylactic shock, again, sensitivity reaction to a food, drug, or substance. This is short, so when we get to that section, it's probably be a 5-minute discussion. All right, so let's look at the pathophysiology of sepsis. Now, it always starts local. So let's use pneumonia as an example. So pneumonia is a local infection, right? In the lung, in one or both lungs. And what happens is if it's either untreated or undiagnosed, therefore untreated or undertreated, okay, let's say the patient didn't finish the antibiotics or we used the wrong antibiotics. So now it escaped local control. It entered the bloodstream, which is easy for pneumonia, right? Because imagine 100 million alveoli all wrapped in a capillary network. So of course, very easy for the organism, especially if it's small enough, to enter the bloodstream. So now you have a blood infection. So now it escaped local control. So this is now what happens. So this immune response, because the organism is now in your body tissues and now enters the bloodstream, it spreads now all over the body. So it provokes the activation of biochemical cytokines. Remember this term earlier? What happens again after you have this? What happens to the capillary membrane? The permeability increases. So now you have increased capillary membrane permeability. So now you start leaking fluid. Okay. So this leaking fluid means what happens to your blood vessels. So this will spread. This may start local capillary leak. Just like when you had a pimple. So imagine who still gets pimples here. Probably nobody. I mean, we're too old. You're too old for a pimple.
What you mean I'm too old?
Anyway, So you notice a pimple, right? Remember you have a pimple when you popped it? What
Mhm.
happened to it after you popped it?
Well, it swells.
Did it heal?
Swells and gets red.
Took a while, right? It got worse, right? It got redder. Then what after the blood stops, because it bleeds, right? After you know, the pus,
Comes
you know,
out.
splattered all over the mirror after you popped it. You got pus all over the mirror with some blood, right? And then the blood stops, right? Then what do you notice coming out afterwards? This clear liquid, right? So that is your capillary leak. So that fluid came from your leaky capillaries. So here you have local capillary leak, but imagine this happening widespread though, because now the inflammatory response, because these biochemical cytokines there is produced systemically. So now every body system have leaky, and then the one that will suffer, of course, is your lungs. Now, this stage, when you reach this stage, we call that SIRS. Now, SIRS has a long criteria. I don't know if it's mentioned here. I can't remember. Okay, let me, so it's not here. Let me just, I'm not testing it, but let me just show you the criteria. Okay, let's go to, different hospitals have a short or longer list. I mean, it's depending on which one they adopt, because there are some of them may add a few. It's actually longer because this is short. There's this SIS criteria is actually very long.
So you're not testing it?
No, because your textbook doesn't have it.
There's a lot of stuff in testing that it's not enough.
Okay, this one from a government website. Let's use this. Okay, so this is a short list of the SIRS criteria, but it's longer than this. But this will be enough for us for discussion. So when a patient comes in the ER or already inpatient, they will be diagnosed with sepsis when they meet one or more of these criteria. Because there's a point assigned to each one, and you only need 2 points to be in SIRS already. So it's really easy to qualify for SIRS. So 1, body temperature over 38 or under 36. Okay, so it goes both ways. You can go hypothermic or hyperthermic. Heart rate greater than 90, respiratory rate greater than 20, and then the PaCO2 is less than 32. WBC 12,000 or less than 4,000. So just like temperature, you can be hypothermic or hypothermic, or this one, you could be leukocytosis or leukopenic. Okay. And but the when you're leukopenic though, the 10% immature bands, this is referring to left shift, no, bacterial infection, because you have a high number of immature WBCs or neutrophils in your specific, no, not WBCs, but specifically neutrophils. Okay. And then once we get into, remember the progressive stage earlier? This is just FYI, okay? So they use a SOFA scoring, which is sequential organ failure assessment. So this is now when the patient goes into the progressive and into the irreversible stage. So they also score you on SOFA. Okay. You'll see more of these at work. You won't see much of it in,
So when they say they're doing the sepsis workup, that's the.
yes, that's what they use. So you'll be, if you meet SIRS criteria, then we will start with the bundle. I'll show you the bundle when we get to the interventions. So let's finish the stages first. So again, stage 1, you have a local infection. Okay, so it's not sepsis yet. It's a localized infection and then it escapes local control. The next stage from local is now SIRS. So that means it's now systemic. So this is the beginning of sepsis. The next stage after you meet SIRS will be, and here are your, oh, I didn't see that they actually enumerated the SIRS criteria here. Okay. Once you reach SIRS, the next stage here, if again the patient is not treated or we didn't identify the SIRS soon enough, now we saw the patient already in severe sepsis. Now we see evidence of clotting. Now, what will prove inappropriate clotting? Now, the doctors will order labs like prolactin. No, sorry. Prolactin and procalcitonin. And rarely they can also, because it's more expensive, they can also order activated protein C levels. All of these indicate inappropriate clotting, meaning why would the patient have inappropriate clotting? Meaning, are they going into DIC? Yes, this is early DIC, okay? So which happens in severe sepsis. So after SIRS, the next stage is severe sepsis. Now the problem here is, remember, when you have massive and the pro-inflammatory cytokines start increasing, right? They keep increasing. So remember the increased capillary membrane permeability? So that gets worse and worse. The result here is what will happen when you have systemic vasodilation now? Remember what happened in the stages in the other types of shock? Let me illustrate on the whiteboard. Where's my whiteboard? Yeah, remember
Blood flow with
my pen.
the blood pressure top.
So let's say here, if this is your MAP, MAP here. And this is, what were the stages of shock, of the other types of shock? Compensatory, right? You have compensatory, progressive, irreversible. So what happened to the MAP as the patient progressed? So it was easy to see, correct? Okay. The problem here in sepsis is, if this is the SIRS, and this is severe sepsis, SIRS is also called early sepsis. This is now shock. When you enter here, yes, the MAP drops, but when they enter this stage, for a short while, a matter of maybe 4 to 6 hours, because those blood vessels dilate, it actually stimulates the heart. The blood pressure improves during severe sepsis, only for a matter of hours though. And then once they enter shock, they drop that fast. But what makes it deceiving and what makes the mortality high is really this section right here. Because let's say the patient was admitted for pneumonia. Okay, so here, pneumonia. What did we do when the patient was admitted? What was the first thing we gave in the ER? Yeah, oxygen, food. Okay, we gave antibiotics. Now, let's say this is now day 2, and the patient got 2-3 doses, right? Let's say the antibiotic was 8 every 8 hours. So we gave 3 doses, or maybe 4 doses now. So here, if you see this, plus, yeah, the WBC was high here. Patient had a fever, right? Now here, because of the stimulation brought to you by the vasodilation, the blood pressure improves. In fact, the patient's color also changes. Guess what happens? Pink. Yeah, they turn pink or even reddish, right? So, and the patient's WBC actually stops rising. It's not because it's improving. It's actually because the bone marrow can't keep up with the, yeah, it can't keep up with the leukocytosis because it's now injured. Okay, so there's cellular damage already. So the WC starts going down, patient's afebrile, temp going down, and they turn pink. Okay, they look pink, and the BP improves. Blood pressure improves compared to admission. Here in admission, blood pressure was low. Now, how do you interpret this? If the patient came in and you started treatment, how will you interpret this here? Is this a worsening or an improvement? This section right here.
It's worse. It looks like they're improving.
It looks like they're improving. Okay, so let me give you an example. So I was a new nurse. Never forget that patient. She was very nice. She was yeah, she downgraded. Her story was she came from somewhere northeast and then she was in Florida, right? So she downgraded to a smaller townhouse. Okay, so something she can manage. And I can't forget it because she told me, "Oh, I wish I had still had money. I would give you money." They do that a lot in the South. Yeah, I would get $20, 30 bucks. I mean, that's not ethical because it's under $50. You're allowed to accept that. Okay? Sometimes they'll say, no, oh, this is not for you. This is for your kids. Okay, what am I going to say? Right? Yes, pizza for your kids. All right. I mean, they're appreciating the care, right? They don't do that to everybody, but they appreciate all good care, good nurse. They'll give you money, right? Yeah, that's nice. So she did that to me. But what made it sad was she was like this. So I admitted her. So this is what she looked like. And then the next day, 24 hours later, this is what she looked like. Her blood sign, and I showed her. Okay. So I showed her the trend. I pulled up the chart. Hey, look at you yesterday. Remember when I admitted you? You felt miserable. Okay, you looked like crap. No, your blood pressure was low, your febrile. Look at you now and look at your labs. Okay. I showed her the WBC, her temperature, her blood pressure, and she was happy. Oh, yeah, you're okay. Oh, and she said, "Oh, because of your nice care." Get out of here. Yeah, I said that. But then that was around midnight, right? 11:30. I checked vital signs, and then 5 o'clock. This is what happened to her. She was like this at 5 o'clock. She was unresponsive. Yeah, she was unresponsive. Blood pressure was tanking that fast. So less than 5 hours. 11:30, around 5:15, I think, when I checked her again, because she was sleeping. Of course, you don't wake up people, no. And we weren't. That wasn't a monitor floor. There was no telemetry there, so I had no idea what was going on with her. So this is what happened. Okay, so it's just a matter of hours. So that's how fast patients can progress between the severe sepsis to septic shock. And had we, been monitoring the lactate levels more closely, we would have been able to distinguish whether or not this was an improvement or actually a deterioration. Because if we check the lactate and it was, of course, for sure it was high, is this an improvement? No, we wouldn't be duped. We would have seen it coming that, oh, you're getting worse. Okay, and then we could have transferred her to telemetry, right? Because she followed textbook. I mean, you could also, I don't know how many of you had COVID, knew of people who died from COVID. This is the textbook pattern. My brother, the brother I lost 2 years ago, 2021, had the same pattern. Okay, so we were FaceTiming, right? Because in 2020, I mean
Yeah.
2021, we were still, we can't visit, right? Plus he was, overseas, 10,000 miles away. So the his youngest daughter was, FaceTiming, hey, look at daddy. I said, hey, yeah, thank you. Yeah, he's doing better. But then when I um hours later, no, she called, she was already bawling, crying. And it just, hit very close to home. This is textbook, it's textbook sepsis. Okay. So that's what was happening to him. So this was happening to him. So he was awake here. He was asking for food. All right. So because he felt better. Okay? He felt before he was, just unconscious, like this, and then he, suddenly there was hyper stimulation because they had the hyper, what we call that, hyper perfusion. Okay, this at this point only for short hours though. So he asked for food, can you get me a burger? And I said, oh, I'm coming back to the clinic on Monday, 'cause that was a Saturday. I'm going back to clinic Monday. Okay, I'm doing better. Yeah, everybody was celebrating. In just a matter of hours. So here, if you read this here, the entire paragraph here, this is what's happening. So here, BP may remain within normal limits or hypotensive, heart rate increases, hypothermia, fever, and then there's of course here, these are consistent with the infection. So you have high CRP, high ESR, okay, high WBC, but then the problem comes when the patient enters that short period, okay, of hyperstimulation. Yes.
So you see how like alcohol has the C after protein, so what if you like something like that?
Well, any infection, any inflammation have high CRP and high ESR. Yeah, they're what we call inflammatory markers. Right, so that's how quick it is. So you have to rely on other than blood pressure because of the deceiving nature of sepsis and septic shock. Okay, so you look at your labs. Is this really an improvement? Right, as you monitor your patients. So let's go to interventions now. So what can we do? As soon as SIRS criteria is established and the patient is diagnosed with shock, we implement the sepsis bundle. So CMS, Medicare and Joint Commission, they establish core measures. What are core measures? These are standards of care. So there's one for stroke, heart attack, diabetes, sepsis, mechanical ventilation. There's one for all commonly occurring problems. Meaning, what's the purpose therefore? So why did the Joint Commission and Center for Medicare, Medicaid, okay, so standardize the care, meaning every time this happens, this is what you do. Think of it as an algorithm, all right? So they dictate, okay, you see this? This is what you do. So if you fail to follow the core measures, can this be a lawsuit? Yeah, big lawsuit. Why didn't you follow the bundle? Hey, we made it easy for you. Okay, so one of them is sepsis bundle. Now there are a series. Okay. I'll go straight to the bundle. Now I'll go back up right here. Chart 11-6. Now this is a series because the patient, remember there was a sentence that says sepsis is an evolving process. Okay. So the first hour here, within 1 hour of identification that the patient met SIRS criteria, this is in order. Okay, you cannot interchange this. Are we clear? This is, you follow this, implement this in this order. Now don't worry, an experienced nurse will probably get this done in under 5 minutes. First thing is you draw blood. There are 2 blood specimens drawn here. One for lactate, one for blood culture. And then start your first dose of antibiotics, followed by fluids, lots of fluids. Look at a 30 ml per kilogram. How much is that? If I weigh 70 kilograms, that's 2 liters. Okay. So that's a lot of fluids. Now, if this is all in the first hour, okay, so if the patient doesn't respond to the fluids, then we consider norepinephrine. We consider vasopressors. Again, I repeat, what's the first thing? So you identify patient, doctor says, okay, patient meets in SIRS criteria. What's the anticipated orders? Draw blood. 2, okay, 1 for lactate and then antibiotics. So that will, blood culture. So that will probably take what, 2 minutes? Okay, you got both samples and then you start the antibiotic. So you hang the bag, start it. So that's what, 90 seconds. Okay, and then now you start another bag, spike a bag with fluids. Okay, in this order. Are we clear?
Yeah.
Okay. And let's say the patient doesn't improve the next hour. Here, within 3 hours, same thing. All right? So you keep repeating. Within 6 hours, this one though, within 6 hours, because the other two have already been done, this blood and these are already done. So all you do, because this is now, way past, this is now in the 6 hours. So you just continue with the fluids and the vasopressors. So all we're doing here is just titrating the vasopressor infusion. The doctor will guide you, he'll give you instructions because we can't do it on our own. ICU though, they have a standing order to titrate vasopressors, but everywhere else you need an order for, because other only ICU can titrate. Right? So that's how you take care of sepsis patients. Okay, we standardize the care.
For your brother, all due respect, for your brother's situation, this.
Of course, they did, they followed the sepsis bundle, but I mean, he just unfortunately, didn't make.
That baby that you were taking care of, the bundle.
Yeah, I checked, but she died because she was no longer in the census. That's all I know. I mean, there was no way she was discharged. I know I transferred her, but then when I came back the third night, she wasn't on the census.
Also, you found her at 5 o'clock, that's when you had the bundle.
Yeah. I mean, I can't start it at the, because it was a med surge floor. First assignment was med surge, so just transferred her, and they started the month.
Oh, so you.
Yeah.
So it's not something where if the person is septic or older.
Yeah, she didn't have a sepsis diagnosis on admission. It was just pneumonia. She didn't have the SIRS criteria.
IRS criteria go like slip through the cracks before.
It can, again, depending on the timing. So you can, yeah, you can miss it. Okay, so let's go back here because we went straight to the chart. Again, you continue treating the underlying cause because again, there are many causes of sepsis, right? So it's not just infection, but most of them, 99% is of course caused by infection. So if it's a UTI, pneumonia, these are the most common. Okay, elderly patients with sepsis, it's usually either a UTI, meaning they became urosepsis, or pneumonia, sepsis, or say a wound, okay, a pressure ulcer that got infected. Again, our goal is MAP of 65 or better. All right, so let's finish up. Let's go to anaphylaxis. Okay, we'll skip MODS because that's really no different from irreversible stage.
This is what the
296 is?
neurogenic,
Anaphylactic first.
296.
96.
All right, this will be quick. So, do you have hours to do this? We have minutes, right? Okay, so this is an emergency. On your exam questions, I'll give you a scenario where this could occur because it could be at home, in which case depends. If the patient has a known hypersensitivity to something, they will already have a EpiPen handy. Or what if they didn't? So that's a possible scenario, right? All right. So let's start with signs and symptoms first. Okay. So they will vary depending on the patient's individual reaction to the substance, drug, or food. So they may start with a headache, lightheadedness, nausea, vomiting, acute vomiting, pruritus, and again, the feeling of impending doom. This is caused by sympathetic stimulation. And then as it gets worse, there's now erythema, so the redness in one or more parts of the body. There could be hives, there could be, what do you call that? Rashes, okay? Flushing, and then comes with the airway inflammation now. So that leads to laryngeal edema. So it closes the airway. Then comes bronchospasm, and then cardiac arrhythmias, hypotension, death will follow. Okay. Now, how does vasodilation lead to bronchoconstriction?
Depends on the receptor on the receptor.
Because remember, this is a vasodilation problem, right? That's why the patient has erythema. There's redness.
It's like a local.
Okay, so let's say this is your airway. Okay, so this is Jennifer's airway. I cut off her head and now I'm looking down her airway. Okay, so her head is gone. This is what I'm looking at, her main stem bronchus. So this is the wall of her main stem bronchus. Is this a muscle? It's a smooth muscle, right? So does it have blood vessels? Yes, there are blood vessels here. So if you have vasodilation, what happens to the diameter of this muscle wall? Again, there's vasodilation. Every single capillary, artery, and vein supplying this muscle dilates. So what happens to the diameter, the thickness of this? Okay.
Low blood pressure, increased blood
You said blood
Listen to me first.
blood
Okay. So remember, this is hypersensitivity, correct? This is distributive shock. So leads to all those biochemical cytokines, okay? Histamines are released, causing widespread systemic vasodilation. Every single blood vessel here supplying this bronchial muscle dilates. This is a muscle, right? So this is the airway. This is where the oxygen is flowing, the air is flowing. This is the size of the airway, normal airway. If all of these blood vessels dilate because of the anaphylaxis, hypersensitivity. What happens to the thickness of the wall? It increases, narrowing the opening. Do you understand? So this is how vasodilation leads to bronchoconstriction. You understand? Okay, so let's go now to the treatment. So we identified, so we call, depends. If this is at home, call 911. Or if you have epi, you give epi, right? Okay. Yeah, if you have it. So we'll do it. So let's go to management. So treatment of anaphylactic shock requires removal of the causative organism or antigen. Now it depends. What caused it? If it was a drug, IV drug, can you remove it? You can stop it. Okay. What if it was a bee sting? Depends. If you can see it, if you, the stinger is protruding out, yeah, you can get a tweezer. Okay. What if you ate it? Well, it's not always safe to induce vomiting, depending on the patient. Is the patient still conscious, right? Right, because you can cause aspiration, right? So it really depends. So what's the first intervention? No. Okay, so after you do that, say stop the antibiotic, or if you can remove the causative agent, if possible, then do that, right? So if at home, call 911. If in the hospital, call rapid response. Okay. Let's forget the fluid management. That will not be your first intervention. What's the first intervention? I am epinephrine. If this is at home and there's an EpiPen, give the EpiPen. So in the hospital, okay, you call rapid response, grab the IM epinephrine. Okay. After you give that, what's the next one? Diphenhydramine IV, because this will stop the reaction, correct? So what will the epi do? Will the epi stop the reaction? No. Epi will only save the patient's life. Okay, so how does epinephrine stop the airway closure? So epinephrine is a vasoconstrictor or vasodilator? Vasoconstrictor. So if we reverse the whole problem, instead of vasodilation, we now have vasoconstriction. So what happens to the wall diameter? It will, right, because now you're constricting the blood vessels, you're opening the airway. Correct. Vasodilator. Same thing as albuterol. Albuterol is a beta-2 adrenergic agonist. So therefore, it has the same effect as epinephrine. So what's the side effect also of albuterol? Tachycardia. Same thing as epinephrine. So this is how it works. Okay. So again, the epi will only open the airway. Will it stop the reaction? No, not whatsoever. So that's why the next drug given is diphenhydramine. And then followed by nebulized medications, albuterol, which potentiates the bronchodilation. So it makes the effects of epinephrine better. Okay, so you have epinephrine and then now you have albuterol. Steroids may be added, but that's not a priority. Okay, the doctor decides whether or not to give you steroids. Depends what was the offending substance. Okay, so what caused the reaction? You may need a second epinephrine in 15 minutes. So monitor the patient within 15 minutes. Actually, we do it up to 4 hours after the event. Okay, because there may be a rebound reaction. Because epinephrine only lasts for how long? About 15 minutes, right? So you can give another dose in 15 minutes. Right, and of course, if the reaction was severe, you go into cardiac arrest, and then can you go into cardiogenic shock as well? Okay, so now you have two problems, okay? And that's it.
Can we
Yes,
also go into distributive?
well, distributive shock is anaphylaxis. Yeah, it is distributive shock. Okay, that's it. Then last topic will be neurogenic. Neurogenic shock is in page 296, right below the table 11-5. Okay, so what are the risk factors here again? Spinal cord injury, correct? So it could be traumatic or from spinal epidural or spinal or epidural anesthesia. So as already explained earlier in the introduction, this is because of the spinal cord injury, there is now a imbalance between para and sympathetic stimulation. So here we have parasympathetic stimulation resulting in bradycardia and massive vasodilation. So this is also pretty quick. So this is as quick as anaphylactic shock. So this is a medical emergency as well. So as soon as you, so therefore, who do you monitor for this to develop? All spinal cord injury patients, right? So you watch the patient whenever you see bradycardia and hypotension. And what happens to the breathing here also? Because this is, remember, parasympathetic. Okay, so there's also respiratory depression, right? So rest and digest instead of fight or flight. So what's your first action? Call rapid response, okay? Because you need orders. Call rapid response, and then what do you expect to be given? Here's management. No, there's no epi here. What's the first intervention?
Elevate.
Oxygen first, and then can we give fluids? Yes, we give fluids, lots of it. Can we, if the patient doesn't respond to fluids, then we can add vasopressors. Okay, so we add norepinephrine. And what do we do with the heart rate? Atropine. That's it.
So for this one, while I'm waiting, that's when I would put them in the enhanced Trendelenburg.
Sorry,
While I'm waiting. While I'm waiting for,
rapid response?
yeah, that's.
Well, meanwhile, what can you do? Remember, this is a spinal cord injury. So what's the position here? Flat, right? You can only log roll. So what position do you put the patient in? What do we call that again?
The reverse Trendelenburg.
Modified Trendelenburg. Okay, so raise the legs.
And
Okay.
leave the head flat.
Yeah, or maybe if there's shortness breath, yeah, you can go up to 15. Okay, no higher than that. But raise the legs,
Mhm.
and that's enough until you get the order or the team comes in. Okay, they'll give you orders. Okay, start the fluids. Okay, or you can have them ready and you're just waiting for the order. Oh, okay, fluids. Okay, I already gotcha. Okay, so you're already starting the fluids, and then if they add vasopressors, okay, fine, and then you already have. They say, oh, give atropine. Got it right here. Okay, all right, and you give already.
But
That's
I
it.
probably prefer that if someone had just, like, someone fell, yeah, spinal cord injury, I could probably assume that, like, I would want to keep them still and then raise the leg.
Mhm.
Okay. Got you.
The rest of the interventions here are now long-term, meaning this is outside of the emergency period, okay? Because this patient has spinal cord injury, right? So immobility, so they're at risk for DVTs, pressure ulcers.
So you put on gun thinners and.